Martina Penazzato, and I'm the Pediatric HIV lead in WHO Geneva. And on behalf of WHO, I'd like to welcome you all in this new webinar of the WHO TeleECHO webinar series, which today will focus on an important topic, the role of faith-based organization in improving the quality of care for children living with HIV. We remind you, the next slide please, that this webinar is translated in multiple languages. So if you do need, you can select the language that you prefer. In the next slide, we also want to remind you that if you need any assistance during the course of this webinar, you can use the chat function. And we'd really appreciate if you could rename yourself so that we can take note of who is participating today. We'll share the slides and the recording link after the webinar. Lastly, in the next slide, we want to note that we, with the participation of this webinar, next slide, you are agreeing with the recording, and that we would really appreciate that the general comments that you'd like to share are shared through the chat box to all the panelists and attendees, but that for specific questions to presenters and panelists, to use the Q&A box so that we can really manage those questions in the most efficient way. You also receive a certificate of attendance at the end of this webinar, and so I'm really happy that you all joined today. So in the next slide, I also wanted to obviously remind you, next slide please, of the overall goal of this series. We know that these webinars were designed and intended as a platform for information sharing and interactive discussion on progress and pending issues on scaling up pediatric and adolescent HIV services in priority countries. And so the overall goal here is to flag challenges, but most importantly, share solutions and trigger technical assistance by various stakeholders at the global and a regional level. In the next slide, you can see that this journey started a couple of years ago with a number of technical meetings that happened in countries and a number of rounds of follow-up that also went through the challenges of facing COVID in different programs, and now are really culminated in this work that we've established last year, and these series that helped us to dive deeper into some of the key topics that are really important for all of us to scale up services for children and adolescents. And as you can see, we really have a great forum here with a lot of partners and colleagues that are joining from countries in their own different capacities. So let's move to the next slide. And as you all know, WHO has really released in July a revised version of the consolidated guidelines. So just want to remind you all that these guidelines are out and are on our website and can be consulted in more detail. And there's a lot of nuances that relate to children and adolescents that might be important for you all to review. So just a reminder for everyone that that resource is available. We also heard in July, next slide, that unfortunately, despite all the progress, next slide please, we still have 1.7 million children that are estimated to be living with HIV. And again, only slightly more than a half of them is receiving antiretroviral therapy. We know there are still too many deaths in the pediatric population, and there's still about 150,000 new vertical infections that are reported and estimated overall. Clearly, there's been progress, but we're still struggling with identifying children, ensuring they're started on treatment in a timely manner, and that they are virologically suppressed and retaining care. So there is clearly a need for all of us as partners in the HIV response to collectively accelerate efforts toward closing the treatment gap in pediatric and adolescent HIV. The next slide is to acknowledge also that among the stakeholders and the critical stakeholders that have a role to play, we have faith-based organizations. We know faith-based organizations have historically played an important role in the response to the HIV epidemic. We know there is an extensive network of facilities, schools, places of worship, as well as linked community social programs and activities that we can leverage And there are strong links as well as reach and influence that can be played within communities to provide a solid platform for advocacy, community education, stigma reduction, and service provision. So clearly important role to play that we want to acknowledge and discuss today. In the next slide, you can see the agenda we'll go over today. We'll hear a bit about the key pediatric initiatives that are linked to faith-based organizations at the global level. We'll discuss some of the specific roles that faith-based organizations can have in the service delivery for children and adolescents in Africa. And we will discuss a few best practices that are important ones that we hope can also be picked up by other countries that have joined us today. And as usual, leave some time for discussion and questions and answers. So with that, I'd like to hand over to my colleague, Dr. Ivy Kaziria, who's joined our team in WHO, and over to you, Ivy.
Thank you very much, Martina, sorry. Thank you very much, Martina, for the opening and the introduction to this webinar. I will now move on to the first part of our presentations. And we are honored to have Francesca Merico and Dr. Stuart Keane, who will be providing us an overview of faith-based pediatric initiatives. Francesca Merico is a passionate human rights and children's rights activist with experience on advocacy around HIV and AIDS with the faith-based organizations, United Nations organizations, and pharmaceutical companies. She currently is engaged with highlighting the role of faith communities in the HIV response through the PEPFAR UNAIDS Faith Initiative and the Faith and Community Initiative. Dr. Stuart Keane is an independent consultant who has worked for the last 20 years on policy and advocacy related to children affected by HIV, and is currently working on an assignment for the UNAIDS PEPFAR Faith Initiative. Dr. Stuart co-chairs the Advocacy Working Group of the Regional Interagency Task Team on Children and AIDS in Eastern and Southern Africa, which is a member of the Interfaith Health Platform and the Coalition for Children Affected by AIDS. They will be making their presentation jointly, and I hereby invite Francesca to start the presentation. Over to you, Francesca, and Dr. Stuart Keane.
Thank you, Ivy and Martina, and good morning, good afternoon, everyone. It's a real pleasure to offer a brief overview of faith-based pediatric HIV initiatives, aim, roles, and achievement. And as it was just said, I'm going to share this presentation with my colleague, Stuart Keane. So next slide, please. So this slide shows what are the current faith initiatives on pediatric HIV. We have the UNAIDS PEPFAR Faith Initiative, the PEPFAR Faith and Community Initiative, and FASTER. So both Stuart and I are engaged in the first two. I'm just going to mention briefly FASTER, which is a program, a global grant from Catholic Relief Services. It's a project funded by PEPFAR to accelerate the pediatric HIV response in Nigeria, Uganda, Tanzania, and Zambia. And it is interesting also for us because it's one of the concrete outcomes of Rome 3, the Vatican high-level dialogue on pediatric HIV that was held in 2018. And also through this initiative, CRS is also implementing part of the commitments taken and that are expressed in the action plan. And the primary focus of FASTER is to develop operational guidance and training materials to enhance local service delivery capacity, but it's also working on studies on the acceptability, feasibility, and effectiveness of caregivers-assisted oral fluid-based HIV screening for children from 18 months to 14 years old. So just a brief mention on this program and initiative as well. And next slide, please. Okay, this is the PEPFAR Faith and Community Initiative, which was launched in 2018 with the purpose to address key gaps towards achieving epidemic control and ensuring justice for children. So addressing sexual violence against children as a key driver of the HIV epidemic. And the initiative leverages the unique capacities and compassion of faith-based organizations and communities, and it seeks to engage communities of faith to reach men and children, also through engaging men with testing and HIV services. It also helps to understand better the epidemic at a community level and to raise community awareness around pediatric HIV through faith community structures. So this page is the homepage of the website of the Faith and Community Initiative, and I invite you to look at it because it contains a lot of the materials, trainings, but also communication prototypes that we have developed for faith leaders and communities. They have been initially used and implemented in the PEPFAR countries, but now the implementation and usage of these tools is much broader. Next slide, please. So we know that faith leaders are really essential to share information in faith communities. As Martina just said, they have a very large network through their places of worship. And we know that in many places, especially in Africa, between 60 to 75% of people attend religious services at least once per week. So for us, it's been really important to build on this reach in faith communities and to build the capacities of faith leaders and communities to share messages that we call messages of hope, that talk about the value and the importance of testing, treatment, and retention for children. Next slide, please. Here again, some information about the material developed, especially focusing and targeting women and pregnant women. Please go ahead. Next slide. Okay, as I was mentioning, we have developed a lot of material, but we have messages of hope on HIV, but also messages of hope on COVID to support children living with HIV that, as I said, are available on the website. These messages include information on testing, treatment, and the value of retention for children and care. And the messages have been adapted for use in faith settings. So they have been integrated into sermons, educational talks, homilies, reflection, prayers, and other religious materials. And everything is both for use in Christian settings, but also in Muslim settings. Next slide, please. Here is a list of the material developed, calendars for faith and religious festivities, posters, WhatsApp messages, guide for religious leaders on pediatric HIV, videos for children and adolescents themselves, and a lot of illustration. There is a lot of colorful materials. And again, this message, the hope that there is behind the idea of a better life because children can access testing and treatment. Next slide, please. So here is the Advent, an example of the Advent messages of hope. The Advent is the period before Christmas. Again, here the faith leaders share with their communities daily messages around testing and treatment and retention. You can go fast on the next two slides, please, because again, it's about the materials that have been developed and they are accessible on the website. Please go ahead. Okay, on this slide, as Martina was mentioning, one of the reasons behind the creation of this eco platform has been really the fact that COVID has limited the possibility for us to meet and to offer training in person to religious leaders and representative of faith-based organizations. So we have created through the PEPFAR Faith and Community Initiative, the new Foundation of Hope webinar series, where we offer webinars and again, share materials and best practices for improving service deliveries to children in faith communities. And here is the list of some of the events that we have offered. Next slide, please. Regarding the UNAIDS PEPFAR FATE initiative, the primary objectives of the initiatives have been to document the contribution of faith-based partners. And this is response of a Lancet series on the role and impact of faith-based organization in HIV and pediatric HIV. So this initiative was launched in 2015 and it's still undergoing. Another important aim of the initiative is to work to sustain and strengthen faith-based pediatric and adolescent HIV response. We work a lot on building the capacity of local, regional, and national faith-based organizations to offer compassionate and evidence-based HIV services. We work and we have several activities, and I think many of the speakers after are going to share about these activities as well that are focused on challenging gender inequalities, stigma and discrimination. And then there is all the part on advocacy, and that is focusing mainly on creating a more coordinated response and advocacy intervention by faith-based organizations, because as you know, there is a lot of diversity among faith groups and the ways that the HIV response is approached. Next slide, please. The UNAIDS PEPFAR FATE initiative has a global component and a national component. As I mentioned, regarding the global component, the coordination of messaging and faith advocacy is very important for us. There is a lot of work on capacity building, networking, and sharing, documenting the role and impact of the work of faith-based organization, also on pediatric HIV, and Stuart is going to talk more about this. We work on strengthening interfaith collaboration and also building collaboration with other sectors. So not to have the faith response as a parallel response of HIV. Regarding the national component, this is a list of countries in which the initiative is operating. There is a lot of work done together with the governments to contributing, creating a faith response in alignment with the government's response. So we are working in developing faith national action plans, but also national pediatric action plans. There is a lot of work, as mentioned before, on trainings of religious leaders on stigma, gender-based violence, and pediatric HIV, and also a lot of work around strengthening the linkage between faith communities and faith healthcare service providers. Next slide, please. Some of the important activity of the UNAIDS PEPFAR FATE initiative, or the FATE initiative is support, are here in this image. So we see, for instance, the pediatric HIV and TB Rome action plan. So the initiative is involved and it's supporting these important exercises done in collaboration with WHO, ECPAF, UNAIDS, and PEPFAR. We are supporting also the, for instance, the GRAIL project, and I know that Landre will speak about it today. There is a lot of work done with faith leaders. Faith leaders lead by example to promote testing in faith communities and encouraging testing of children. So the specific campaign, and a lot of awareness raising activities involving children in religious schools in the countries that I've mentioned and they were listed before. Next slide, please. Another important piece of the initiative is to generate collaboration and sharing of promising practices so that those that are successful and effective for service delivery are scaled up. And here we have an interfaith health platform, which now is engaging 1,700 representatives of faith-based organizations. So there is really a lot of work of sharing of materials, of promising practices and exchange among the different groups. Next slide, please. Here, I just wanted to show the way we operate also in the country. So in each of the countries, there is a steering committee, which is coordinating the sharing of messages into the different communities. So we work with the head of the different denomination, churches or mosques to make sure that this, the messages are shared and then the communities are engaged. Next slide, please. So here I pass on to Stuart, who's going to conclude with the current project that we have. Thank you.
Thanks, Francesca, and good morning, afternoon, and evening, everyone. I want to briefly talk about one of the current activities of the UNAIDS PEPFAR Faith Initiative and the Interfaith Health Platform that Francesca just mentioned. It's a study of the role that faith communities play in pediatric and adolescent HIV programming, and it's still being finalized, but we hope that this short presentation will whet your appetite to find out more. So the UNAIDS PEPFAR Faith Initiative is collecting and documenting evidence about promising practice interventions undertaken by faith communities on pediatric and adolescent HIV. And this is outlined in this slide. The rationale for the study is that faith communities who include faith-inspired health service providers, faith-based organizations, faith community groups, and religious leaders, that they are making a significant contribution to meeting the needs of children and adolescents living with and affected by HIV. But these initiatives, they're not well understood, principally because they're often not documented. So the study, which is, you can see a little bit of a questionnaire in slide 2. The study has included a literature review, an online survey, the questions of which are in that next slide. We've also had some selected follow-up interviews with key informants. So 55 potential interventions have been identified, and this has been narrowed down to just around 40. We're still expecting a few more, but we're impressed with the quantity and the quality of what's been submitted. So these interventions cover a wide range, probably around 10 different areas of pediatric and adolescent programming. But the 4 most frequently mentioned are, firstly, access to ART, retention and adherence. Secondly, identifying and testing missing children. Third, HIV and health awareness. And fourth, adolescent HIV prevention and life skills training. The literature review highlighted that faith communities make their contributions using 4 distinct assets. And if you go back to the previous slide, you'll see those mentioned there on the slide. So based on that information, we structured the questionnaire. But it's based on these 4 distinctive assets. The first of which is service delivery through faith-inspired health service providers. Secondly, community outreach through faith community groups, be they for women, for men, or for young adolescents. Thirdly, using places of worship to create demand for HIV services. And fourthly, advocacy by religious leaders and FBOs about traditional practices and various bottlenecks and government commitments. But all of the country examples in this webinar that follow are included in the compendium. You'll be pleased to know, so you're getting a further whetted appetite. We're currently finalizing the compendium that documents these promising practices, and we look forward to sharing the findings in the near future. Thanks very much.
Thank you very much, Francesca and Dr. Keane, on this very interesting overview. And before we move on to the next presentation, I am seeing a couple of hands up among the participants. I'd like to remind all of us to kindly use the Q&A function. If we have questions, can post your questions in the Q&A, and we will be responding to those throughout the webinar. I'll be moving on to the next presenter. The next presentation is on the role of FBOs in service delivery for children and adolescents in Africa. And we'll be having the presentation from Nkata Njeru, who is with the African Christian Health Association platform. Nkata Njeru is an experienced public health professional who has worked with the faith sector in Kenya and regionally for the past 17 years. She is the team leader for the Africa Christian Health Association's platform and an umbrella an umbrella organization for Christian health associations with membership in more than 30 African countries, whose mandate is to support healthcare systems and of CHA members. Nkata, you are most welcome to make your presentation.
Thank you, Dr. Ivy. Next slide, please. I will not say too much about this because Dr. Ivy has already introduced ACHAP, but we are a regional organization. We work with Christian health associations at national level in various countries, and nationally, the Christian health associations are organized as mission health facilities. We currently have membership in 43 member organizations from about 32 countries around sub-Saharan Africa. Next slide, please. So ACHAP works to facilitate networking and communication among Christian health associations and other church networks. We also facilitate joint advocacy, as well as support the capacity development of Christian health associations to enable them provide quality healthcare. We also work to establish and maintain partnerships with other institutions. Next slide, please. This data needs to be updated. However, the last survey we had showed that about between 30 to 70% of national health services in different countries is provided by the faith-based health system. And when you look at the remote or deprived communities, faith-based health systems tend to provide up to 90% of healthcare. Next slide. Next slide. What are the distinctive competencies of the Christian health associations? You find them prominent in fragile nations. They also tend to have strategic partnerships with governments. They support healthcare that is provided by governments. They're also noted for innovation and local solutions because they happen to exist within communities. They also have a foundational mission centered on the value for compassion, happen to be pro-poor and for rural rich. They have the capacity to mobilize communities. Francesca just talked about 60 to 70% of populations in sub-Saharan Africa subscribe to a religion. They also have the timeless commitment and stability grounded on the Christian faith. Whereas projects come and go, faith-based health systems exist and continue to exist in communities beyond various projects that happen in communities. They also have the social capital of trust by communities, and they happen to be health system buffers and provide resilience in emergencies. We have seen that through the COVID response, the Ebola response, and others that have happened in our continent. Next slide, please. Specifically talking about our approach for HIV response for children and adolescents. One of the things that is very prominent is that in a lot of communities, you will find 3 safe spaces: a school, a church, and a hospital. And the way these have been established in many communities is that they happen to be mission centers, where there's a church, a school, and a health facility existing together. So mission, one of the approaches that the faith-based health systems have tried to use is to try and create a linkage between these 3 safe spaces in order to respond. We also use the approach of the religious leaders have a captive audience, which we have mentioned, the previous speaker also mentioned. Well, of course, with the COVID situation, we have not had captive audiences every week. However, our religious leaders have ways of reaching those audiences. And then they also have trust of communities. as well as the continuity and sustainability because they are grounded in these communities. They are also community-based stakeholders, are trusted resources, and are often the first point of contact for information. And as well, being gatekeepers, they have the influence and the voice for their communities. So these are some of the things that we have capitalized on as we work in communities. Next slide, please. That's a photo of one of our activities working with religious leaders for children and in HIV. So we worked together in a project that was funded by USAID to develop guides that were helping religious leaders to talk about HIV in children. I will talk about that later. Next slide. Next slide, please. So the Christian health associations as national organizations or through the mission health facilities in the various countries provide service delivery at facility level and at community level. So children and adolescents receive care and treatment at facilities. We also work to mobilize both at the local level, at the local level through the facilities, at the national level or international level through the Africa Christian Health Association platform or the Christian Health Associations at national level. We advocate for equity, coverage, and access. For example, we have done quite a bit of work in helping to advocate for medication for children. We also participate in health policy development and health sector planning at national level through the Christian health associations in the various countries. We also contribute to the body of knowledge through M&D and research in the various countries. Christian health associations in various countries have medical and nursing colleges that train health workers through the colleges, as well as providing the critical workforce that is needed in the various countries. As part of our membership, we also have what we call the drug supply organizations that are organizations that the Christian health associations have formed to provide affordable medications for communities through a supply chain that is affordable in various countries, such as in Kenya. We have the Mission for Essential Drug Supply. We have BUFMA in Rwanda. We have Chan Medifarm in Nigeria. We have Uganda has the joint medical stores, and others in other countries, such as Zambia, where they also have a supply chain that provides affordable supply chain to the mission health facilities. Next slide, please. So talking about some specific roles, working with communities and religious leaders directly, we try to create connections between the faith leaders and the healthcare system at all levels, so that the faith leaders, when they come across people that need care, are able to then link them with the health facilities. We also build the capacity of religious leaders, because one of the things that we have learned is that communities are as informed as their leaders, and religious leaders are gatekeepers to communities. So if they do not have information, then communities too do not have information. I will mention a case of a training we held, and the questions that you will get in communities are the same ones that the religious leaders will ask. As simple as, how do you get HIV? Specific questions of, if I shared a toothbrush, would I get HIV? How does a child get HIV? If the child is breastfed by their mother, will they get HIV? So our religious leaders need to be informed, because if they do not have the information, then they can't pass it on to communities. Then adaptation of materials for support of faith leaders. So we have been engaged in development of Kuta and sermon guides, working with with all religions, because we are existing in communities. We therefore cannot work with only the Christians. So we bring together academicians, faith leaders, and health workers, and work on sermon guides that help the faith leaders to be able to refer to religious materials and talk about health from them. So we have those. If you go to our website, you'll find some of those materials that we have developed and specific for children and HIV. Then we do joint implementation of health projects with faith leaders, where we involve them. When we talk to communities, they become our champions. We also create safe spaces and try to work with we work with faith leaders in communities to have churches and mosques as safe spaces for these children, adolescents, their parents, and their guardians. And also what I talked about, connecting our safe spaces, the school, the church, and the health facilities, so that we have them talking together. One of the methodologies that we have used is a methodology that you can look up, which is called the framework for dialogue. That we have tried to use and bring together the faith leaders, the school teachers, the healthcare workers, to talk about the situation of stigma and discrimination in the community, and then come up with actions together that they can implement towards elimination of this stigma and discrimination. Then at the health facility level, we have peer support groups where children as well as adolescents come together. We have treatment days so that children can be attended to on a specific day, as well as adolescents, so that the healthcare worker has, for example, a Wednesday is the day, or a Saturday, because children are going to school. So some of our facilities have come up with children days, so that on that specific day, they're only seeing children or adolescents, and they're able to provide spaces that respond to them appropriately. There have also been mothers to mothers support groups where guardians and parents of these children can come together and talk about their issues. And then staff rotations in facilities, so that all the staff in the facility are able to come to the comprehensive care centers and take care of children, and be able to support them in various departments of the facility. Then sensitization and education of the healthcare workers in the facilities, so that they respond to the needs of the children and adolescents. Workplace policies, protocols, and procedures that are responsive to the needs of this group, as well as patient charters that respond to their needs. Specific engagement of young people at the health facilities, so that we create a safe space or a room where these young people can come and talk to each other, and also having healthcare workers that are responsive to their needs. Healthcare workers that are young and understand the needs of the young people and can talk their language and can be able to engage with them, as well as specific psychosocial support at the healthcare facility. Those are some of the specific roles that we have played as faith-based organizations to respond to the needs of these children. Next slide, please. Next slide. So what lessons have we learned? I think this is a common one, that nothing for the children and adolescents without them. So if we want to do anything for them, we need to make sure that we involve them, so that whatever we do is what they think is their need. And then I have talked about communities that are as informed as their leaders. So building the capacity of communities, the teacher, the administration, the faith leaders, and then the need to think about sustainable approaches to initiatives, so that even when projects end, whatever initiatives we start can continue in these communities. So one of the ways we have done this is using religious leaders, not just the pastor, the imam, the sheikh, but religious leaders, youth leaders, women leaders, men leaders, as champions, so that whatever we do, even if we leave those communities, even if we are working through a funded project, will then be sustainable. We have also learned that communities, when engaged, have creative innovations for their own challenges. So whenever we are trying to create a project, we also try to bring in the communities to think about what innovations they have that they can bring in. I've talked about leaving no one behind, and also I've talked about religious leaders as advocates and champions for the children can make a great difference. Thank you. Next slide. Thank you.
Thank you very much, Kata, for that wonderful presentation. Indeed, very interesting. Any questions, once again, should be posted in the Q&A section and will be handled by the various presenters. We'll go now quickly to the poll. Next slide. We have a quick poll that we'd like to conduct. Having heard about all the interesting, the potential of faith-based organizations, their reach and their capacity, would like to ask the panelists a simple poll question. On which programmatic components should HIV services by FBOs be strengthened? This is a multiple choice poll, so you can actually select more than one of the options. We'll do this very quickly to obtain your views. The next 1 minute, please vote. On which programmatic components should HIV services by FBOs be strengthened? Based on what we've heard so far from the global perspective and the regional perspective on the role of FBOs. Please vote, select one or more of the answers as you find pertinent. Okay, any feedback? How far are we with the poll? Thirty more seconds to have a look at, to vote, such that we can have a look at our results. Oh, wow. So basically, I hope we can all see the poll responses and what the participants' view is. It is basically a view of everyone here that almost all the components should be strengthened. And this is quite interesting information. So this will be taken note by the FBOs around. That the view of the participants is that all the components need to be strengthened alongside one another. So we'll move on to the next presentation without too much ado. We are now moving into the country experiences. We have 3 interesting presentations. Starting with a presentation on a best practice for testing and linkage to care. We are honored to have with us Dr. Lanre Olaiwola. I hope I pronounced it correctly. He is the Associate Director for Care and Treatment, Caritas Nigeria, and he is a medical graduate of the University of Ilorin. He holds a master's degree in infectious disease from the London School of Hygiene and Tropical Medicine of the University of London, and he is a diplomat of the Faculty of Family Medicine of the South African College of Medicine. He is a seasoned public health physician and currently an associate director in a public health implementing organization in Nigeria. You're most welcome, Dr. Lanre, to make your presentation. Over to you.
Thank you very much, Dr. Ivy. It's my pleasure to be here. Good afternoon from Nigeria, everyone on the call. I'll be making a presentation on the role of faith-based organizations in improving the quality of care for children, focusing on testing and linkage to care, using Nigeria country experience. Next slide, please. So let me start by saying that this program, this particular intervention was implemented by Caritas Internationalists and Caritas Nigeria. Let me just say one or two words about Caritas Nigeria. Caritas Nigeria is a creation of the Catholic Bishop Conference of Nigeria, and is saddled with the responsibility of implementing the humanitarian intervention of the Catholic Church in Nigeria. It's an NGO registered and is independent and autonomous, and by virtue of our background, we are a member of the Caritas family that is headed by the Caritas Internationalists. So on this premise, Caritas Internationalists work with us to implement this project, not only in Nigeria, but also in Zimbabwe, as well as in the Democratic Republic of Congo. Next slide, please. So I'll quickly tell us what is, this is my outline for presentation. I'll be talking about GRAIL and process and procedures and what result we got in the course of our implementation. Next slide. So I'm sure you want to know what GRAIL is. So GRAIL simply means galvanizing religious leaders for accelerated identification and linkage to pediatric ART. This is a program that is focused on to test and identify children who are living with HIV through religious leaders and their platforms, and link them to appropriate intervention. And so that's what you're going to be seeing here. The principal, the actors here are the religious leaders and their religious institution. Next slide, please. So the faith community are asset areas, and essentially it's about the advocacy to religious leaders and faith-based organizations, as well as using the platform of worship places to be able to serve as springboard to intervene and identify children who are living with HIV/AIDS in different geopolitical zones of Nigeria. Next slide. So how did GRAIL work? Remember, GRAIL is galvanized religious leaders. The first thing we did in this intervention was to, build on the conceptual, on the concept we had earlier, which is congregational-based approach to HIV testing. Many of us on this platform will be familiar. We have had one presentation on this earlier, where we talk about our congregational-based approach to HIV testing, where we increase, case identification among pregnant women. So GRAIL is actually it's a progression along that line, and now we are directing our focus to pediatrics in this case, and that's using the same principles that underlie the earlier implementation in the congregational-based approach to HIV testing. At this point, we are targeting, destigmatizing HIV, especially among religious leaders. We are trying again to use the same understanding of the influence and the leverage that religious leaders have to serve a purpose of, tackling stigma, and at the same time simultaneously identifying HIV-infected children. So what that means is that if you can use instrumentality of the toolkits to be able to disseminate messages and information that are HIV friendly, we are increasing the confidence of the people, and we are inadvertently reducing the potential, disposition of stigma towards HIV and all associated diseases. And by so doing, we're going to get more people demanding. So we're creating a demand for HIV testing services using the religious organizations and institutions. So one of the key components on implementation that will soon be obvious in the course of this presentation is training. So in the course of training religious leaders, we are able to identify people we now refer to as activated clergy. These activated clergy, in other words, are champions. They are religious leaders and faith communities who have been trained on pastoral and basic scientific considerations. So what we did essentially in the training was to, just like the earlier presenter said, what we did was to make sure that we develop some customized messages, adapt and adopt those messages to suit the various religious platforms and organizations, so that it becomes appropriate for their audience. And that's what the training does. Beside that, we also give them basic layman information about the scientific considerations that underlies HIV, so that they can use this information to help in identifying children who will need to be tested, and ensure that they are referred to appropriate places for their test. Next slide, please. Next slide. Okay, so you want to know how we are able to simulate our religious leader. There are quite a number of desk activities that precede, the training itself. So all of these activities are what we group together as, pre-training phase of intervention. Now, what we did first and foremost was to do a mapping of the prevalence of HIV in Nigeria. This particular project was implemented in 2018, and in 2018, that was just a period prior to the recalibration of HIV epidemic in Nigeria. So we have a pretty clear understanding of what we are trying to do. Nigeria is divided into 6 geopolitical zones, and our aim is to identify states and subnational units where the prevalence of pediatric HIV in particular is quite high. And on that premise, we are able to identify places where this intervention will take place. So we use the geopolitical zone to cluster states and subnational units together for trainings and intervention. We also try to focus on religious organizations and institutions that have parallel health facility, that are intervening on health facility, have one intervention or the other. What I mean by this is that what we try to do essentially was to make sure that the religious organizations that we are working with are such that also have some health institutions that is part of them. So, for example, most Catholic churches and Catholic churches and Catholic parishes, and they do have health facilities that they create and they support. So we actually identify such, even in Islamic faith and other denominations equally have same. So we try to identify such religious bodies and make sure that we are able to, bring them on board. Because in the course of our training, one of the things we did was to make sure that for every of the parishes and every of the religious, congregation that is involved, where we are involving their priests or their parish leaders in the training, we also select corresponding leadership of the health facilities that is within the catchment area of that particular, religious congregation. By so doing, we have been able to create a network that make referral easy and possible. So that was the platform on which, our selecting the religious leaders as well as the health facility participating in the project was based. Next slide. So let me quickly say that when we say a clergy is activated, we're talking about clergy that has been assigned, that has agreed, that has been trained, has understood, and has agreed to take up certain roles and responsibilities. So because this time around, we know that clergy's primary responsibility is to, preach to their congregations, or develop sermons and take care of them, holistically. But beyond that, we're also trying to bring in some additional responsibilities that directly relates to what we want them to do. And basically, we want them to be able to interface with the children and their parents in their congregation about the immunization status of this. Now, understand that we are adopting an integrated approach. We are not trying to make this a kind of HIV-centric intervention, so that we can also make sure that we are, we're not creating unnecessary attention to what we are doing. The implication is that if we focus only on HIV, it means that the priest, whenever it's trying to interface with anyone, it can begin to create a mentality that, okay, this is all about HIV. So we bring in immunization. We also ensure that we are able to train them on how they can identify and screen patients using some simple tools, which I'm going to show us next, on when children have fevers, diarrhea diseases, or even some respiratory tract infections and skin infections. So these modified balancing tools, which I'm going to show next, it makes it very easy for a priest to be able to identify a child. So this is the tool that I have just referenced now. So what we did was to train all the priests on the use of this tool. So a priest just simply administer this tool, and on the basis of the response provided in the course of administration, is able to identify children that requires referral. So some of this referral is done for all children that show any signs here, and you know that some of these signs are also signs that can underlie possible HIV infection. So all children that are so referred for any of the medical conditions here listed are going to be profiled and investigated for this condition as well as HIV. So that's exactly the way the activated clergy work. Next slide. So the activated clergy, having have their responsibility clearly defined, are expected to carry out what we call catalytic activities. Now, remember I said activated clergy are clergy who have been trained, who have understood the impulse of our training, and are ready to take up the responsibilities that Grail, impose. So one of the things we expect them to do is to regularly undertake what we call catalytic activities. And these activities are: number one, identification of church health advisor to drive congregational intervention. So for all these congregations, we want them to look inside, look at their congregation and identify individuals with health background, nurses, community health extension workers, and all the likes. These people are called church health advisor. They are part and parcel of the congregation, and they provide, the technical parts of intervention. Then we expect the activated clergy to, provide HIV messaging during homily and preaching. Of course, remember, one of the goals of intervention is destigmatizing HIV. So by so doing is, by bringing in awareness and sensitization to the people of HIV and how it is not what many people think it was, creating that stigma, is able to create the same activation in the members. Then awareness and sensitization. So, in churches and in religious institutions, there are specific days that are celebrated. For example, Work Sick Day. We expect those such celebrations to be used as an opportunity to further create awareness and sensitization, as well as ensuring constitution of possible parish health committee and other committees that will complement the efforts of the activated clergy in the congregation. Next slide, please. So those are the catalytic activities that the activated clergy is expected to carry out in their various congregations. Next slide. So this clearly just gives us a succinct insight into the implementation approach. So one, we have identified the congregations. We expect that there will be increased awareness. Increased awareness will lead to case identification. Case identification will result in referral for pediatric HIV testing and linkage. So that's the cascade of events that overhacks the entire thing that we're doing. And of course, this involves parents and children, mothers and children. And by giving messages and creating awareness, we are able to increase index of suspicion from those mothers and parents in the congregation, so that any health-related events are identified and appropriate referrals are done. Remember, we're also using the church health advisors who are present and can provide even on-site intervention in situations when immediate referral is not possible, or can provide immediate accompanying referral to the nearest health facilities where a comprehensive support, clinical and medical interventions can be provided. Next slide, please. So just to give you an insight into what we did, we were able to work across the 6 geopolitical zone in Nigeria. Although when you see my data and the results, you might realize that it's focusing mainly on, it wasn't like in the Northeast, we also had the Muslim clerics range. However, Nigeria has some security challenges that hamper interventions and continuous follow-up of activities in the Northeast. That resulted in an inability to be able to collect data for that part of the region. However, this intervention we're able to implement across all the geopolitical zone in Nigeria and across religious, the 2 main religious practices in Nigeria. Next slide. So let's quickly see what our result looks like. Next slide. So to start with, we were able to train 179 religious leaders, and that of course include 89 priests. We also have the people we call religious, the administrator for hospitals, especially for Catholic hospitals, they are usually Reverend Sisters. So they are also part of the training. And we also have trained people, we also selected people from catchment health facilities that are closest to the particular, religious congregation we are reaching out to. So in addition to that, remember I talked about the cascade. The cascade is first of all messaging. The messaging is pivotal to this program. So we're able to reach out to 21,712 people with HIV messaging that promote diagnosis and treatment of children living with HIV. Of course, the focus is to reach out to adults because adults are the custodians of the children, and it's their understanding that can enhance, the needed outcome of this intervention. So we are able to, report either achieve 21,112 adults that were reached out to. Then we're able to identify 21,142 children that were referred for HIV testing. 21,130 of them, which is almost 100%, were tested, out of which 106 positives were identified and then linked to treatment. So that was the phase 1 of our GRAIL intervention. And you can see the disaggregated figure in terms of male and female and age, disaggregated along less than 5 and greater than 5 in the slide. Next slide, please. This was implemented between April and July 2018. Next slide. So this is just a breakdown of religious leaders across the trading, across the geopolitical zones, and across the various platforms that are there. So you can see in total we have 179 people that attended the training. 89 of them are priests. The religious people, like I said earlier, were 11 sisters who are hospital administrators or catchment hospitals that those religious institutions are affiliated to. And then many of them, 97 of them belong to parishes, and that's looking at both the priests and the religious. And then 41 of them are healthcare workers that are taken from health facilities that are within the catchment area of the congregation that are participating in the training. And so in total, after all the trainings, remember we talked about champions, we talked about activated clergy. So after the training, it's not all the people that are trained that eventually gets on board. So we're able to identify 85 champions who are committed and ready to carry out interventions as they were trained. So next slide, please. So this is the breakdown of the trainings and the outcome. Next slide. So this is just talking about just previous slide, please. One step backward. So this is just talking about the breakdown of the cascade of intervention. Messaging, you can see the number of people reached with the messaging, then the number of people referred for testing, and the number of people tested. So I just want to, the emphasis here is that we are able to achieve 89% linkage, 0.5% yield. And I will also reference the fact that the national AIDS indicator and national HIV AIDS indicator in index of survey that was done in 2018 actually puts the prevalence of HIV among pediatrics in Nigeria 0.2%. So this is something that is slightly higher than what the national prevalence is, showing the efficacy and efficiency of this method of these strategies in identifying children even with HIV and AIDS. Next slide, please. So after next slide. After the implementation of grade 1, because of the results and the achievements that grade 1, we got approval to proceed and implement grade 2 and even 3. Now, next slide, please. Grade 3 has gone as far as now being a great intervention methodology has been adopted and integrated into the FASTER implementation project. FASTER is an above-site level implementation that enhances and supports national HIV program. Now, as I speak to you, FASTER has adopted, this is one of the strategies that FASTER has adopted in the implementation of the activities in Nigeria and I think beyond. So as a result of the results we got in phase 1, 2, and then we have also implemented phase 3 and in conjunction with FASTER. Next slide. So let's see what the result of our phase 2 and phase 3 intervention looks like. In phase 2, which occurs in July to December 2018, we were able to identify, we reached over 3,000 persons with HIV messages, stigma reduction messaging. And then out of this, over 22,000 were children less than 15 years. And we using the balancing tools that I earlier highlighted and the trained clergies that were already on board, we were able to get over 16,000 recurrently sick children under 5, referred for HIV testing. 15,000 of them were tested and 64 positives were identified. Again, the yield at this time was 0.4%, still slightly higher than the national AIDS prevalence as well, but slightly lower than the previous in the phase 1 of the implementation. I also want to say that 62 of this one was successfully linked to ART and were initiated on antiretroviral treatment, which gives us 0.7% linkage. Next slide. So for grade 3, I just quickly, one thing that I couldn't add in this slide because of time and the volume required is that in grade 3, we have also improved on these strategies by bringing in an easy to use electronic point of service data collection tools. And that also helps us to, number one, fine tune our data collections to get granular details of the data, as well as ensure that we are able to get real-time data, harmonization in the database. So that happens because, in the grade 3 implementation, we're able to bring this on board. Remember, we're doing this alongside with FASTER. So that is additional, value an improvement that we're able to bring on board in the implementation of grade 3. So grade 3 in total, we're able to identify, get 612 children, you know, and if you look at the grand total here, we have 2,812 children that are tested all together in grade 3. Next slide, please. And then these are the places, and I particularly put this to show that these things are not just taking place anywhere. They were taking place in church environment, religious congregation environment. So these are the congregations where this testing takes place. And you can see that altogether we're able to identify 9 positives, and all 9 positives were successfully linked to treatment. It's also very important to state that this grade 3 actually happened between March and July 2021. Remember 2020, late part of 2019 and 2020 was essentially the period where, you know, COVID-19 did not allow a lot of things to happen, and activity, churches were shut, mosques were not operational, so we were not able to do much up until when, you know, the COVID situation allowed us to start intervening. And that was why the grade 3 implementation came as late as March to July 2021. Next slide. So this is just looking at the next slide, just looking at the summary of what we find in our grade 3 intervention. Like I said earlier, we have 9 positives identified, all 9 were linked to treatment. And, you know, that was at 0.3% linkage, which though lower than the previous 2 interventions, still slightly higher than the national prevalence. So clearly you see that, you know, overall, the religious institutions, religious leaders and interventions using religious platforms actually substantially and significantly contribute in no small measure to advancing pediatric HIV care and treatment, as well as, more importantly, in ensuring that these children are identified and appropriately linked to required intervention. Thank you. Next slide. Thank you for your attention.
Thank you very much, Dr. Lanre, for this very interesting presentation on your program. Without too much ado, I will run into the next presentation because we're running short of time. We'll have a best practice from another setting, and we are privileged to have Father Rick Bauer to give us his experience from the EDAP program. Father Rick Bauer is a Roman Catholic priest, a board-certified chaplain, and a master's level social worker. Since 1982, he has worked and advocated for a true biopsychosocial spiritual model of comprehensive care and support for the persons affected by HIV. Father Rick, you're most welcome to make your presentation. We're running short of time, so appreciate it if you keep the time. Thank you.
Well, great, and I will, and try not to speak too fast for the interpreters, but thank you very much for this invitation. And Ivy, as you said, I was so glad to see that in the word cloud, comprehensive care was one of the highest. And I think that's what I mean by this bio, psycho, social, spiritual model of care. Next slide. So we were founded in 1993, and I say this because it was one priest and one nurse rooted in the community that was going to make sure no one died alone. And people often ask, well, how do you scale up? How do you scale up? And the best advice I can give is slowly. I think we've seen the disaster of scaling up too quickly. But right now we have 14 clinics. Most are located on and the same grounds as faith communities. We have about 30,000 HIV positive clients and currently about 1,600 under the age of 18. We provide comprehensive HIV and TB services, but again, looking at a bio, psycho, social, spiritual model of assessment, care, and support across faiths, and this also includes members of key population groups. We do have point of care diagnostics with a real-time electronic medical record, and somebody asked in the question, we developed this ourselves. I got a young graduate in computer science who developed our medical record for us. It's also important that we look at the ethos and the values of our clinics. And we ourselves really use Catholic social teaching, especially the inherent dignity of every single person that comes to our clinic doors. We look also at caring for workers. We look at caring for the very poorest of the poor. Next slide. I just show this. This is where we're working, not an easy place to do any kind of public health intervention, and especially COVID interventions. But my belief is that the church should be where government is unwilling or unable to be, and eventually to turn this over to government. Next slide. So the whole focus of our intervention is called OTZ, or Operation 000. And this is for our intervention with children and adolescents. And what this means is 0 missed appointments, 0 missed doses, and 0 viral load. And heroes are zeros. And so I walk into a clinic and the young person sees me, they know what I'm going to ask, and they say, yes, Father, I'm a 0. And that's, again, the ethos and the values of where we're at. Next slide. So this shows, again, where we came, that in 2016, only 68% of our kids and 64% of our adolescents were virally suppressed. And you can see it takes time. But if you implement comprehensive care, then you can get to those 90s. You saw in the children, a little dip during COVID. We're still trying to figure out some of the whys of this, but hopefully we can get this back. But again, with our adolescents, up to now 93% viral load suppression. The next slide. So again, this is comprehensive care, looking at the child, looking at the caregiver, looking at the clinician and their skills and abilities, and then looking at the community environment. So it begins with prenatal care for all mothers, whether the mother is positive or negative in the community, and using HIV positive mentor moms, especially for that emotional and social support. We are linking all of these pregnant moms with one of our community health workers. We have regular scheduled family clinics. And I just noticed this, some of our data, when we need to keep physical distancing, but still women come together and they support each other in the waiting rooms. And this is critical and very key. The continuity of care involves intervention for both the child and the parent or the caregiver. We are also very blessed. We have an electronic medical record and point of care diagnostics so that clinicians have the data. You cannot expect a clinician to implement good comprehensive care unless they have the data. Consistent supply chain management and pediatric formulations and consistent lab reagents are essential. And as many of you know, during the last 18 months has been a disaster in getting good supply chain management in many of our countries. Next slide. So we're going to look at what are some of the components. And when I say a bio, psycho, social, spiritual model, it means not only doing good clinical physical assessments, but it's working with clinicians, getting social workers to look at the psycho, the emotional needs of our clients, the social setting and understanding what this person's unique social supports are, and also doing a spiritual assessment. This is not just saying, would you like me to pray for you, but it's understanding this patient's, this child's, this parent's unique spiritual beliefs. How does their faith impact their medical decisions? Do they believe in faith healing? Do they believe in miracles? How can we integrate both of these into care? We have monthly support meetings that are focused, a big focus is on disclosure because we know how important that is, but not forcing disclosure, but talking about how and when and where to do this. We have day-long activities, especially during school holiday periods, and again, COVID with appropriate physical distancing. Everything focuses on Operation 000. 0 missed appointments, 0 missed doses, 0 viral load. Taking those tablets same time every day. We also do a lot of peer support, and I was horrified when I first saw this, because of confidentiality, but it seems to work in our slum areas, that we take the kids that have low or viral loads or undetectable viral loads, ask those kids to raise their hands, ask the kids that have high viral loads to raise their hands, and pair them, put them together for that mutual support. Especially during COVID, we have closed WhatsApp groups. That is, for the adolescents, has been really key. And also multidisciplinary team meetings every week to discuss those clients that have a high viral load. Next slide. Home visits, making that link between the faith community, the clinic, and going into that local community is absolutely key with both the community health worker and the case manager. Parents need support and assessment, and often we're so focused on only assessing and supporting the HIV positive child. We also need to provide that same support and assessment for the parent and guardian, regardless of their status. Every child is paired with the community health workers, and then our community health workers can provide data and contact to the clinic through a mobile platform on their mobile phone. Disclosure is key. We also work with site team leaders to identify staff with the abilities, the gifts, the talents, the grace to work with children. People don't want to hear this, but not every doctor, not every nurse likes kids. So find those that do like children and build their skills for pediatric HIV care. In our clinic, the child sees the same clinician every visit because relationship is such key to understanding this child's unique challenges and support them on adherence. Next slide. So again, our community health workers, about 1,400. This has been integral to our program since its founding. The management and the staff see our community health workers as essential and integral to our community, to our clinical services. They are not on the sidelines, they are the core of what we do. All of these community health workers are from local faith communities. We're now have trained our first Muslim community health workers that are part and from their communities. Faith is their motivation. Faith is their support of strength. And so I bring this up because understanding their needs, their spiritual support is absolutely key. We then also train them. Some questions have come up. These are the people, because they're part of the faith community, that can often serve to work and train their local pastors, religious leaders, imams, okay? They're already part of the community, they're respected in the community, and they're often important follow-ups, and often thank the religious leader if they've mentioned HIV in their homilies and in their sermons. Next slide. So that's, again, I just want to stress, if you want comprehensive, if you want that 90% or the 95%, you have to do comprehensive care. My criticism of many of the multilaterals is we have medicalized this pandemic. That's why you only have 40 or 50% viral load suppression. If you provide comprehensive community care, looking at all dimensions of the human person, then we will get to the 95. Thank you. Merci. Asante sana.
Thank you very much, Father Rick, for that wonderful presentation and reminding us about the importance of comprehensive care. And I'd like to congratulate you also on your excellent viral load suppression rates and in giving us an overview of how you arrived at those rates. Thank you very much once again. We'll move on to the last presenter with the last best practice from best practice in community-based service delivery and ensuring quality of care. And we have a presenter from Circle of Hope. I'd like to introduce Gibster Makangila, who is the Executive Director of Circle of Hope, the community-based partner FBO. He has worked in HIV/AIDS since 2003, managing grants from PEPFAR, CDC, USAID, in the sensitization, testing, and linkage to treatment and care. We are honored to have you, Gibster. I hand over to you to give us your experience in community management.
Thank you very much, Ivy. And good afternoon, good morning. Next slide. Thank you. Circle of Hope has been around since the year 2005. And like Ivy has said, we've been engaged in community-based intervention. And notably, in the last couple of years, 2 years, 6 months now, we formulated and crafted a model, we call it the community post model, that was a direct response to some of the barriers that my previous panelists have alluded to. And those barriers are the ones that have been inhibiting some of the performance on the HIV cascade of care, which includes poor case identification, poor retention, and of course, poor viral load suppression. And so in the last couple of years, we have brought into treatment over 25,000 new clients only within the Circle of Hope family of care. And prior to that, we had 3,005 over a 13-year period after this model was designed. That is user-friendly, not only to adults, but to children as well. We've seen a phenomenal result of 25,000 being added within the same district of Lusaka. And so what we have done is to leverage a very important aspect that has been mentioned already by my colleagues. And notable is the issue of relationship. So we have leveraged relationship that exists in the community and tapped into great wisdom arising from the faith community and also the local community. And these three communities enjoy trust that my colleague has referred to as capital, community capital, and also two other very important nuggets. Number one, access to household. They're accepted very easily with new information, new data. And number three, they understand the local environment. They have intricate knowledge in as far as the trends, the lifestyle, the hotspots, and everything in that community. Next slide. And so what we have done is to identify those barriers that have been preventing the HIV sector world from really quickly achieving the 90-90-90 or 95-95 and ensuring epidemic control. So the first one was stigma. And so in as far as children are concerned, we have overcome that by ensuring that all the centers that we have opened, which are called community posts, have been able to be user-friendly. We don't have any scary branding on those places. And so we leave them to be as natural as possible in tandem with the environment where children already live. So we've opened these community posts in places where these children live and socialize, and also where their parents work from. We've also gone further to locate them in places that are only a few minutes nearer where they live. And further, we've also, like Father Rick said, we've majored on a very important aspect of poor customer care. Customer care has been a challenge in our sector because of treatment fatigue, not only arising from the side of the clients, but also from the side of the recipients of care and also the providers of care. HIV has been with us for a while, so it is possible and human to get tired. And so what we have done is to introduce a concept, a core value we call the recipe. And this is the way of thinking that enables the healthcare provider to place a premium on the total and well-being of the client. That includes children. So these are not just numbers, they're actually real human beings with real challenges and real experiences. And last but not least, we've also overcome the issue of time. People are busy, people have to go and trade, have to go back to work. So we've developed a service chart of time that within 30 minutes to 1 hour maximum, every person, every child, every guardian must be attended to. Next slide. Next slide. Thank you. And so before we developed this holistic model, we had children over a 13-year period, about 142 of them on treatment. After the model, in 2 years, we now have 883. And so we've seen an increment of indeed over 700% of children coming on treatment. What's significant about this is that overall, for adults, HIV and other areas, we have seen a 1,200% increment. And that has been made possible because we've collaborated and are still working with over 1,000 pastors, priests, church leaders, imams, and others in a monthly and weekly collaboration that has been ongoing. What are some of the case identification strategies that have helped us focus on reaching out to children, keeping them on treatment? We have a few. We have PMTCT, that is been conducted at churches where we have women of faith encouraging other women at gatherings to ensure that antenatal and under 5 clinics are done by faith champions. This includes members of congregations who are themselves faith champions or faith leaders, and in some cases leading specific women groups in those churches, encouraging congregants to bring their children for HIV testing and also for those who are already on treatment, wellness of their babies. We have also leveraged index testing that for some of you who are not familiar, this is where we elicit all the contacts of any person that tests positive. And therefore, we use the faith community to actually find and solicit using an approach we call the work strategy to ensure that every person that is positive, we actually elicit their children and their sexual partners and ensure that they're tested and brought to treatment accordingly. Through these community posts that are currently 150 across the country in all the 4 CDC-supported provinces, we also leverage these national immunization days where kids are brought for various immunizations, and then we take advantage and sensitize their parents or guardians and test where appropriate for HIV. Next slide. All right, that's just a typical picture at the community post. These are one-roomed facilities located in markets, churches, and busy residential settings. But kids come in numbers to get the immunizations, and through that, we take advantage for those who are stunted, those who are sickly, those who are looking weak, and any symptomatic conditions of HIV, we solicit and get permission from parents to have them tested. Next slide. We also use the Know Your Child status. This is for children who maybe have been missed out during the PMTCT. Mothers are encouraged by the faith leaders to bring their children for testing, and elicitation is conducted upon every visit. Like Father Rick said, and also Dr. Landry, we also utilize Sunday and youth meetings where children through Sunday school are provided with messages of hope that Francesca referred to. So these messages of hope for both HIV and COVID are given to children both electronically through WhatsApp group, online services, and we also utilize vocational children camps. This includes children going on vocational camps where they're taught on religious issues, but then on top of that, we add HIV topics as well. And an incredible arrangement of that is how we've utilized boarding schools. Children in boarding schools, some of them are already on treatment. We sensitize their headmasters or headmistresses to ensure that they take their drugs accordingly. Next slide. Next slide. Thanks. The previous slide. We've also been very happy with one CDC approved, PEPFAR approved intervention called Coaching Boys into Men. We are currently training 42 teams of 20 boys across the city of
Hello? Have we lost Gibster? Gibster seems to have fallen off. Okay, Gibster seems to have fallen off. Apologies for that. We will go ahead with the program, and when Gibster comes back, we will allow him to just at the end to summarize his presentation. So that is unfortunate, but as we wait for Gibster to come back, I would like us to head into the panel discussion with questions and answers. Once again, I'd like to invite all of us, if we have questions, to post them in the Q&A function, such that your answers, the panelists can, the presenters can answer your questions on that platform. I will now be handing over to Dr. Wole Ameyan, who is the Adolescent HIV lead at WHO headquarters, to take us through the panel discussion and moderate the question and answer session. Over to you, Wole.
Thank you so much, Ivy. And I was just, I was getting into the presentation by Gibster. I think it's just, it's amazing the depth and the wealth of information that we have gone through during this session. So it's just, it's really great. I hope Gibster can come back and
yes,
and summarize.
Wale, I'm actually back.
Right.
Yes, I had a power outage. Sorry about that.
Absolutely.
Yes, I can take very few minutes just to summarize because of time.
Okay. Oh, okay, great. Because of time, let's summarize and then we go into the Q&A. Thanks, Gibster.
Thank you. Can I have the slides back?
I think it's coming.
Okay.
So Gibster, just because
yes.
of time, if we can just round up
please.
and then
all right.
Q&A.
Yes, please. Yeah, so I was going to say that one of the things we've done is to develop youth-friendly corners and children-friendly corners. And so these are the strategies we're currently using that have given us this very large yield from where we're coming from. Next slide. All right, so this is the Coaching Boys into Men in action. So every weekend we meet 840 children between the ages of 6 to 18 across the city of Lusaka. Next slide. All right, this is now the data, talking about the data. If you notice, this slide is talking about the linkage. Since we brought on board the faith community, we essentially are having from December 20, where we had 94%, and others, we're essentially having 100% linkage to treatment for every child that we find. And the positivity yield is averaging between 5% and 9%. As of July, we had 6%. Next slide. All right, this is a comparison of our partner facilities, which are non-faith-based. This is the community posts in Southern Province that are doing exactly what we're doing, but they're not involving the faith community. And look at the difference. They are averaging between 88% linkage and 100%. But in terms of positivity yield, they're between 0% and 3%, and 5% for March 2021, and 3% for May 21. Next slide. So we have embarked on giving children and adolescents quality-focused services by ensuring that we book their appointments for all children on a particular day where we have a child day. This is because of limitations of schooling, and also to reduce the stigma as well, where children are seeing so many persons coming for treatment. And so this has helped us to also formulate some drug formulations that are user-friendly in terms of the way we disbase these drugs. And also, we've identified and immediately initiated on ACT all with frequent monitoring and with consent from guardians or parents that are involved or looking after those children. Next slide. All right, MMS, which is a multi-month treatment of or provision of drugs, has really helped for children who are in boarding schools. I did refer to that earlier. And then through the Know Your Child status activity, we've also ensuring that all kids are coming for the immunization doses at the appropriate time, and they're also taken care of and tested for HIV accordingly. And so then for those who are retarded or stunted, we're also monitoring them on a month-by-month basis to ensure that their treatment compliance and adherence is up to scratch. Next slide. All right, so now this slide does compare an equal number of community posts in Lusaka that are running with the faith-based community and those that are running independent of the faith-based community. Notice the difference from October 20 to July 21. This is the TX for the community posts. These are clinics offering HIV treatment. Those running with the faith-based community have been growing steadily and are now 874 compared to those who are running by themselves without leveraging the relationship I talked about. So the gap is so clear, and to see for us to see the efficacy and impact of leveraging the wisdom and knowledge found in the faith community. Next slide. Again, this is an example of the TX curve between October 2020 to July 2021 for 40 community posts. And this is how they have delivered in terms of adding more children and more adolescents coming on treatment. Next slide. And so we have strengthened the adolescent support groups again and to keep adherence fatigue by appointing a focal person for each group. And so interactions among the youth and the children are done every Saturday. And then we're also matching counselors to match children. We don't want to have very old counselors because our counselors and community health workers range from 16 up to 74. That's the oldest. But then we are matching them according to age. And then we always remind the guardians of children 2 days before the pickup and the actual day for coming to visit at the clinic. Counselors are always trained and retrained in disclosure counseling to keep defaulting. Next slide. The Circle of Hope community health workers and faith leaders together prioritize home visits. Remember, I talked about the faith communities having access to households. So we've leveraged that by ensuring that our community health workers are accompanying the faith leaders for home visits where necessary to check on the children and support the guardians and ensure that there are no missed appointments, like Father Rick said, and also ensure that stigma is really reduced by meeting them away from the CP or facility. And for kids with difficulty guardians, we do a one-on-one counseling and teaching and help them to accept that and appoint persons who work with them to ensure that direct observed treatment is happening. Next slide. All right, this is the last slides indicating the levels of children under faith-based treatment that have been monitored. Notice how in this slide, we only lost 2 kids, and one of them died. One of them was brought on treatment much later. Out of all those who were tested and were positive, 18 of them, 16 were linked, and 1 eventually died, and the other one was not brought on treatment immediately. If you next slide, if you compare to the next slide, this is now a non-FPO. They brought in 6, and out of those 6, they didn't have any losses in terms of death, but the linkage is still lower than for a faith-based organization, as the data can show. We also have a higher transouts among the non-faith-based organizations. Next slide. All right, so it's very clear that the faith community has a role to play for us to win by 2030, and therefore we have to ensure that viral load monitoring for children is done within the group, and we also are leveraging all those relationships that exist in the faith community to ensure that we're reaching out to the whole person as mentioned by Father Rick. Next slide. All right, I'll skip this slide. It just shows the suppression rate that we have at 92% as the last quarter and 98% among adolescents. And this is all for the faith-based community clinics. Next slide. Thank you so much for your time. I had to run through because of time. Thank you so much. You can pick it up, Dr. Wale.
Thank you so much, Gipster. You know, I could listen to you forever. There's just so much. There's so much in there. Unfortunately, we don't have enough time, but we have something working for us. We have an excellent group of presenters and panelists who have gone into the Q&A box, and I can see here that, you know, they've practically answered all of the questions that you've put there. So thank you very much, you know, to the participants. You've asked really relevant questions, but, you know, specifically to the panelists who have, you know, responded to the questions. So my role here is just to, you know, rather than go into an elaborate discussion, I would just like to touch base with the panelists and probably just pick a few points from their presentations and see if, you know, we can drive a few discussion points. You know, to my mind, there are 3 things that have come out of these presentations. You know, the first thing, which I think we're clear about and we're beginning to see, is, you know, the critical role of faith-based organizations, faith-based initiatives in the work that, you know, we all hold dear. I think there are 2 other things which I think we need to probably discuss more and unpack. And those 2 things are potential and opportunities. It feels to me like, you know, there are endless opportunities in terms of engaging with faith-based initiatives, in terms of leveraging, you know, the advantages of them in helping with, you know, this the HIV response. And that would be my first question to Francesca. You know, you've given an overview of the initiatives and the impact that they have at the global level. So Francesca, if you could just help me maybe delve just a bit more into how we can exploit this potential, the full potential of faith-based organizations to address the gaps that we have. Francesca.
Thank you so much. Well, it's a difficult question. So I think that to sustain a bit and strengthen the contribution of faith, I think the first important step we need to take and continue taking is to have a better understanding of the contribution of the faith sector to pediatric HIV. And also both I think Gibster and Frederick have made reference to the holistic model of accompaniment and care that shows in the, for instance, the elevated viral suppression in Frederick's, for instance, model. And so I think what it's really important is to better support faith-based organization to document results of this bio-psychosocial and spiritual approach. And we need to do a bit more around that piece as well. I think also that one important piece is that the faith contribution to pediatric HIV should not be considered a parallel contribution to the pediatric global response. And so there needs to be more coordination and collaboration with organizations like yours, the World Health Organization. And I know we have a lot of activities together and a lot of exchange, but I think this needs to be done more at country level, more and more at country level. And this continued exchange between global and national and local is very important. So we know that, for instance, in countries like in Kenya, we have done a study for the UNAIDS PAP for Faith initiative, and the study has shown that across Kenya, 24% of all the treatment visits are provided to children living with HIV by faith service health providers. But again, we talk faith, and we are talking about faith-based organizations separately from other organizations. And I think that we need to find ways to better coordinate and collaborate. I think that one important piece, and that several people have been talking about, that is around we need to keep building the capacity of local, regional, and national faith-based organizations and faith leaders to offer compassionate and evidence-based HIV services. And again, this needs to be done in collaboration with other sectors, and it needs to be done interfaith. And I think one of the important elements of both the UNAIDS PAP for Faith initiative and of the PAP for Faith in Community initiative is that we are building on structure that are existing, and that we are promoting interfaith collaboration and activities. And then sustainability of funding. So it's, I think that these are the elements and the points that I would highlight now. And I know we have not much time, but I could keep going on.
Yeah, fantastic. I mean, I couldn't agree with you more, especially on, you know, moving away from working in silos and, you know, having, you know, two different parts rather than two conjoined parts that are working together for the same common good. So, I mean, we don't have time, but if we did, I'll probably come back to you. But let me go to Nkata. Nkata gave a really, you know, pointed presentation on service provision and service delivery. I think, you know, inequality, of course, is at the center of how we provide services, but also, you know, the gaps that we have in providing those services and in attaining our goals. It seems to me that, you know, I mean, it's the bane of our times, isn't it? You know, we have on the one hand people who are able to, you know, access services the way they want, but then the other part is the vulnerable populations in Qatar. We know that, you know, children and adolescents are vulnerable and they have worse outcomes in accessing services. But even subgroups, you know, of children and adolescents based on, you know, where they live, the income quintile, and other indices. This sort of is a huge barrier. And I wanted to, you know, catch you on that in Qatar. Could you possibly, in very, very briefly, highlight some of those successful, innovative approaches that have been used in countries to address these barriers, these inequality barriers, especially for access to marginalized children and adolescents? Over to you, Nkata.
Thanks. I think one of the niches that we have as faith-based is we work in hard to reach, poor, we're pro-poor, and work with marginalized communities. So one of the things that has worked very well, and I saw that as one of the questions that somebody asked, is the faith-based community working as advocates for these communities. One of the best examples I can use for now is the example in the COVID response and trying to avail vaccines even to those communities going beyond HIV and AIDS. So one of the best approaches is taking up our role as faith-based for advocacy for children, for adolescents, for women, and ensuring that they can access treatment, they can access healthcare from both the faith-based health facility as well as the public health system. So that has been one of the roles that we have tried to play as much as we can to ensure that there's equity, there's coverage, and there's access of services by people in these communities that we very well know, because the public health system is very much available in cities, in towns, but in many of these places, in the slums, in the rural hard-to-reach areas, we find that's where the faith-based is. And just to follow on what Francesca was saying, then being able to document these and bringing them up on all the tables that we sit on. So making sure that we are available on those tables where policies are being made, where decisions are happening, that the faith-based find their space and talk about for these communities. Thank you.
Absolutely fantastic. I couldn't agree with you more. I think the natural role, as you know, as what you're saying, the natural role of faith-based organizations and the natural link that they have with, you know, I thought I saw that in your presentation, with schools, with hospitals, with, you know, with the community as safe havens, you know, has certainly a crucial role to play in delivering services for vulnerable populations. Now, those services, obviously, and we've seen this a lot in the presentations, they have to be integrated. It's across the cascade. We're not just talking treatment here. It's you know, all through that cascade of prevention, testing, treating, retention, virus suppression. It has to go all through. And that's where I'm going to go to Dr. Olaiwola, who as well gave you know, really interesting presentation on that model in Nigeria. From what you presented, you reached large numbers, you know, with testing, indeed with a higher yield than what we see as the national average. And I wanted to ask you about that precisely. How can, from your work and your experience, how should programs increase you know, case finding? And how can we make sure that, you know, the work that you do and the approaches are more targeted towards improving the yield of testing as well? Dr. Olaiwola.
Thank you very much, Dr. Wole. Thank you for that question. First and foremost, we need to understand that pediatric HIV/AIDS intervention generally lags behind adults, and they tend to receive less attention when it comes to, you know, ramping up case finding in particular. So we first and foremost need to understand that there are root causes of this, you know, unusual retardation in the progress we are making with respect to pediatric HIV care and treatment. So one of the first things that is key is to understand that stigma is one of the major problems that makes case finding very difficult. And that was one of the things that Gray was out to actually address. Now, remember I said in the course of my presentation that religious leaders are highly influential. In fact, I remember, I think it was Father Rick's presentation that mentioned the fact that one of the major problems why people even drop out of care or they don't seek care is because of faith healing. So the thinking is that if we use the same platform that tend to make people to that affect the uptake of HIV testing services to address it, it's going to work. And that's what we obviously see in our intervention. So to answer your question directly, I would say awareness creation using highly influential individuals and people like religious leaders will help to increase the uptake of HIV testing services. So when you increase the demand side, so there is a willingness and there is an inclination, there is a desire for people to even get tested. That is very key, because if you make the testing available and the desire to take up the testing services is not there, it's going to be a problem. So one key thing is to address this through an awareness creation that systemically address stigma and discrimination as far as HIV is concerned. Secondly, is to not to sit back in the health facilities, take the service out to them, because more often than not, if you don't actually look out for them, because HIV/AIDS, number one, especially in under 5, can accelerate and actually will result in mortality sooner than you think. You may realize that those children may even die before they get to the hospital. When they do get to the hospital, it is already late. So one of the major strategies, an outreach approach. And that's again why our testing services were not done in the facilities, they were done in the churches, in the mosque, within the precinct of the congregation. So as the messaging goes out, there's also an immediate opportunity to assess those testing. So outreaches, but the outreaches has to be guided. It has to be guided by mapping, which is what we did earlier. We want to know where are the clusters or the prevalence or the conditions, because they are not evenly distributed everywhere. And that's also why we deploy a tool called the balancing tool. The balancing is actually a risk stratification tool, so to speak. It helps us to be able to know we don't have to test everybody. We need to test people that need to be tested. That's what balancing tools help us to do. Help us to identify people who should be tested. Then the one which I will also advise cautiously is incentive. One of the things that is key, and this is one of the things we try to do in our program, is an incentive-driven approach. If people usually get, attracted to do things, however, there are unintended consequences if you do deploy incentives without putting appropriate measures in place. But one thing that is key is that a majority of programs also simultaneously implement what is called orphan and vulnerable children, loss of intervention. In places where this happens, it's also good to align these two programs. And religious institutions and congregations are already prone to providing social services and humanitarian interventions. If we can route our OBC interventions and services through this religious organization and program, where we already align the opportunity for HIV testing, it will also help. And that's the next level that the great intervention is also trying to adopt. So if you put all of this together, we'll definitely be able to increase our case finding among pediatric population. Thank you.
Fantastic. I sincerely wish we had more time. Unfortunately, we're running to the end, but we really interesting conversation, and I'll just go straight to Father Rick. We can't unpack what you presented on. The concept for me is about a whole of person approach, not just the medical side, the health side, but overall well-being. What you're looking at, and what you termed the biopsychosocial spiritual model. I would love to hear more about that, but I just wanted you very quickly to give us a message in terms of programs in different settings. How can they, work, using the lessons that you've presented in your presentation on improving viral suppression and retention. Those are bottom lines for ART. Father Rick?
Well, and Dr. Wole, I'm going to put the challenge back on you and WHO. We need you to help us with better evidence-informed and evidence-based screening and assessment. We have good screening tools looking at viral load, looking at CD4 counts for the physical well-being of kids. We have some emotional things that are evidence-based, evidence-informed, even if it's like depression, anxiety, and stress thermometers for my staff to use with kids to see where just basic emotions are at. We need to hire social workers. I had to fight and fight and fight with PEPFAR that this is key to understanding the social well-being. And then my expertise is now looking at what are the ways to assess and understand this patient's spirituality, so that at the very beginning, my clinical staff is saying, hey, Wole, we've talked a lot about your physical well-being, but here at EDARP, we care about all of you, including your faith and religion. Would it be okay if we talked about that for a minute? So that at the onset of treatment, this is coming up. What we discovered is that it's almost eliminated people dying from going off their medication and seeking only faith healers, that we can combine faith healers and medicine together. And so it's coming up with better assessments, especially for the emotional, the social, and the spiritual well-being, and looking at people like me that have done some of this and using the expertise of the WHO to help us with this. You're too focused on the body. And if we want viral load suppression, we've got to do comprehensive care. Amen.
Absolutely. I mean, that's a good. And thank you, Father Rick. It's a good segue as well towards letting Gipster probably have the last word, because what Father Rick said, in the end, it's about people and communities. What we do, at the global level in countries, what it boils down to are the people who are receiving this care, who need this care, and the communities, in which they live and they reside. So Gipster, you have the last word on, the communities. You've had a great presentation. Sorry you were cut off there, but how can we, better leverage communities in this work?
Thank you very much, Dr. Wale. I think in closing, I'd like to say just a few things in under a minute. Number one, children will remain children and adolescents, so they have to be reached at their level. So we need to ensure that we decentralize all our service provisions in the environment that children are familiar with. So once we have any other environment that is intimidating to children, then we have a potential for defaulting, we have potential to miss things out. So the environment, and secondly, the approach, the customer care to children, the language we use, the pictures we use, and also the pamphlets that are children friendly. Number three, we need to partner at community level with organizations that are children familiar or children friendly. And number four, and last but not least, the usage of games for children. And so let me end there and just echo one last word that Dr. Landry said. We use affirmation and celebration to children. All those kids that are doing well, we affirm them, give them gifts, and then we also use role models for children. Children always look up to somebody. It may be a teacher, a doctor, or a fellow child that is doing well in terms of treatment adherence. So those are the few things I can say. We need to tap wisdom from the community. Thank you very much.
Thank you so much, and just fantastic. All of you have been, super great. I mean, I have a few points here. I'm not going to read them out. I think your points have been made. You've been clear. You've been loud, and I think it's great that we've had over 200 people, listening to you. I think you've really made your point. Something I'm just going to say before handing over to Ivy is that as we move towards 2030 and towards those 95 targets, when we reach there, the faith-based initiatives and the faith-based organizations are going to have a big say about that as well. So thank you so much to all of you. Perhaps we can have maybe a round two of this fantastic webinar as I hand over to Ivy. Thank you.
Thank you very much, Wale, and to all the presenters who have participated in this panel discussion. This was definitely a very, very rich discussion, and only limited by time. There was a lot. It was full of wisdom, and I truly enjoyed the experience. So we'll just have to wrap up now. We've run over time by a bit. We'll be wrapping up by quickly covering, having an overview of what we have listened to. Next slide. We have been privileged to hear about the FBO's capacity to complement national programs and listen also to the opportunities that are available, considering their deep penetration in communities, especially deprived communities. We started off with an overview of the main global initiatives that active, the UNAIDS PEP for Faith initiative, PEP for Faith and Community Initiative, and FASTER, their roles, their activities and achievements. We were also graced by Nkata's presentation from the Africa Christian Health Association's platform, whose network spans 32 countries. And she highlighted the importance of harnessing and leveraging FBOs that are in the communities and giving FBOs a strategic advantage for service delivery in communities. And the extent of their contribution to the national level was presented, particularly the significant role in reaching the last mile. Those are the remote and marginalized communities. And we also heard that religious leaders as advocates and champions for children can make a very big difference. Next slide. We had from best practices from 3 organizations in 3 countries. We started off in Nigeria with Caritas Nigeria, who presented their experience with the Grail project that used activated clergy strategy to address stigma, identify and link HIV-infected children to treatment. And to note, there was a very interesting use of a screening tool by faith leaders, and a reminder of the difficulties that the COVID pandemic has imposed on organizations providing services. And we also had a very interesting experience in testing, where they tested large numbers of children with a yield that was small, although above national prevalence. Which also highlights the difficulty of actually identifying children who are living with HIV. We had an experience from Kenya with Father Rick from the EDAP program, providing comprehensive, holistic, person-centered care services in the slums of Nairobi, using the biopsychosocial spiritual model of care across faiths to achieve impressive viral suppressions and retention results. And in particular, he had emphasized scaling up slowly and provided us with practical solutions to addressing the problems. Again, the importance of child and adolescent health providers, the friendliness of the service provision, and as a pediatrician, I could not agree more. He closed emphasizing the importance of comprehensive care, the holistic approach. We had a presentation from Zambia, the Circle of Hope, that is engaging faith leaders and deploying faith community members and health workers to decentralized community posts. And we had the various models that Gibster presented to us. Next slide. We had a panel discussion that was very rich, and I will not reiterate what was discussed because it was very comprehensive. With that, I would like to close the webinar, the discussion part of the webinar, and it has been very, very fruitful. I hope you feel the same way too. Before we go, I'd just like to remind all of us, as we do with each webinar, is to use the family at the center approach in all our interactions with our clients, especially in this time, difficult time of COVID with all the restrictions, to utilize that one interaction with a client to provide, and Father Rick, you will agree with me here, a holistic approach of services, a comprehensive package of services, such that the clients can access everything at that opportunity. Next slide. Just reiterating the availability of the toolkit, which is online. Next slide. The AIDS-free toolkit is available for you with, next slide. Yes, and this is what it looks like when you log in, and it has the whole set of tools that you would like to access on the WHO website. Next. In addition to this, next slide, please. In addition to this, there is the new pediatric ARV dosing dashboard, which is a drug dosing tool for prescribing ARV medications to children up to 18 years of age. Next slide. And in addition to that, we have also a new document on the toolkit. It is a policy brief on the transitioning of to the 2020 optimal formulary, 2021 optimal formulary for ARVs for children and adolescents. This policy brief outlines key considerations to facilitate effective transitions to more clinically appropriate regimens as optimal ARV drugs become available for children in the country. Next. This is a kind reminder that we do have upcoming webinars. Our webinars run on the second Tuesday of every month. We have the next webinar on 5th of October, and we will be excited to be presenting the comprehensive postnatal package of care at the next webinar. Please note this in your calendars. We have some interesting presentations coming up. The webinar in December will be an extraordinary webinar on the 14th of December. Please note that as well. Next slide. Before I close, I would just like to bring to your attention two other platforms, just so that you're aware. We have upcoming the International Pediatric HIV Symposium in Africa, the IFASA Symposium, which will be taking place on the 17th and 18th of November 2021. Please register for this symposium on its website, www.ifasa.org. The deadline for abstracts passed, but please register to attend the webinar. And one other platform that we have upcoming is the PALCA, which is the Pediatric and Adolescent HIV Learning Collaborative for Africa, which will be held on the 20th and 21st of October of 2021. Please mark your calendars for these events. And with that, I would like to bring this webinar to a close. I would like to especially thank all the presenters for the very interesting and informative presentations and for participating in the panel discussions with very rich information. A special thanks also goes out to all those involved in preparation and coordination of this webinar, and to all the participants for your kind attention. Thank you very much for attending. See you in October. Bye.
Thank you. Bye-bye, Ivy.
Bye.